Good morning, good afternoon, good evening. I would like to welcome everybody to our quarterly global grand rounds for the American Academy of Otolaryngology and Head and Neck Surgery. Today's global grand rounds are on practice management of chronic otitis media and hearing loss. My name is Maria Serna, and I'm the international coordinator for American Academy of Otolaryngology and Head and Neck Surgery. And I would like to welcome all of you to this event. We have a great number of registered attendees. We have about 1,415 people registered, and they represent about 126 countries. So if you're in the chat, you can share where you're from. So we'd love to see that. I would like to pass it on to Dr. Troy Woodard, who is the president of American Academy of Otolaryngology and Head and Neck Surgery, to give a few remarks. Please, Dr. Woodard.
Yes, thank you, Dr. Serna. Hello, everyone. Thank you so much for joining in. It's truly a privilege to welcome you to today's Global Grand Rounds. And it's on an exciting topic, practice management of chronic otitis media and hearing loss. And this, as we know, is an important topic that affects all of our patients around the world and in different regions, regardless of, what is going on. We still have a duty to take care of our patients. We still face similar challenges, and it's really our, I guess, wanting and desire to be here is really because we share a common mission to improve the lives of our patients. And so I just want to let you all know that this webinar program is part of our Academy's ongoing commitment to deliver high quality, accessible education to help empower you as an otolaryngologist to provide the best care for your patient. And before I turn it back over, I just want to really extend my sincere thanks to people who made today's webinar possible. First, Dr. Maria Serna. She's our international coordinator. She has been doing an excellent job and working tirelessly to advance the global collaboration and education. Thank you, Maria. To our moderators, Dr. Greg Basura and Titus Ibikwe, thank you for creating an exciting agenda today and guiding us through these complex clinical discussions. Thanks, Greg and Titus. I want to give a heartfelt thanks to all of our today's esteemed speakers. You're going to learn a lot. They're going to provide a lot of insight and they have a lot of experience in dealing with this. Finally, I just want to let you know that we are grateful for the partnership that we have with other otolaryngology specialties around the world. And I want to give a shout out to the African Otology Society and the Confederation of European Otolaryngologists Head and Neck Surgery. Thank you for collaborating with us. This helps just really exemplify the unity and shared purpose that we have. So in conclusion, thank you all for being here. And on behalf of the American Academy of Otolaryngology Head and Neck Surgery, I wish you engaging and impactful learning experience. All right, back to you, Maria. Thanks.
Thank you, Dr. Woodard. As Dr. Woodard mentioned, our today's global grand rounds are in collaboration with the African Otolaryngologic Society and with the European Confederation of Otolaryngology Head and Neck Surgery. So Dr. Greg Basura is the founder of African Otolaryngological Society, and I would like him to say a few words to further introduce this foundation and a society. Please, Dr. Basura.
Right. Thanks, Maria. I appreciate this. Appreciate the opportunity. Welcome, everyone. It's a pleasure to be here. I'm really excited about this Global Grand Rounds. I'm currently the chair of the Humanitarian Efforts Committee, and I spend a lot of time in Africa developing partnerships. And it's really an honor to give a few minutes to the African Otologic Society that we started in November of 23. As with many societies, the whole goal of this society is to build community and education opportunity, particularly as it surrounds Africa regarding otologic care and audiology. So we launched this as a virtual once-a-month meeting in November of 23, and proud to say we had our 18th meeting just this last month, where it's a full 1 hour, where we discuss a featured country per month. And we talk about capacity of otology as well as audiology in those countries. And then we talk about interesting cases. So I'm really excited about this. I think it's starting to really build capacity and community. I encourage everyone to look on the website, which is listed here. The website is developing, and we're creating a clinical blog on the website so that we can actually have ongoing discussions about interesting cases throughout the world, particularly as it relates to Africa. So it's really exciting. I really like to invite everyone to come to our next meeting, which will be August 30th, 11 a.m. U.S. Eastern Time. And I'm happy to answer additional questions about that after the presentation if anyone has any questions. So thanks again for allowing me an opportunity to present this. Really excited about this. Thanks, Maria.
Thank you, Dr. Basura. Now I would like to introduce Dr. Ann Hermanson, who is president of the Congress, upcoming Congress of the European Otolaryngology and Head and Neck Society. And Dr. Hermanson is a professor at Lund University in Sweden. And please, Dr. Hermanson.
Thank you very much. I'm very, very honored to be able to say some words to you now. And I would like to invite you all to come to Sweden and Gothenburg next year in the spring. The meeting is the meeting of the Confederation of European ORL-HNS, which is a real mouthful. And it is approximately American Academy, but it's only every second year. Because every second year there is a meeting of the specialty societies in Europe. So this is really for all specialities, for all the specialty society and all the national societies of Europe that organizes this meeting. And this time it's going to be in Gothenburg. We can take the next slide. Gothenburg is a city on the coast, the second biggest city in Sweden. The conference venue is situated in the middle of town, as you can see on this picture with the 3 towers. The town is situated just by the coast with a fantastic archipelago, so I would invite you to come and really visit this exciting meeting. We have a lot of people already involved in making the program, and it looks amazing. And also to spend some days on the coast of Sweden. So welcome to you all, and thank you very much to be able to join this session today, which I'm very much looking forward to.
Thank you, Dr. Hermanson. And now I would like to introduce our moderators. The moderators are going to introduce the speakers and lead the discussion on practice of management of chronic otitis media and hearing loss. You've already met Dr. Basura, and who is also the chair of the Humanitarian Efforts Committee. But Dr. Basura is also a professor of the Department of Otolaryngology and Head and Neck Surgery at the University of Pittsburgh School of Medicine. And his main research is focused on tinnitus, single-sided deafness, and multisensory integration in the brain. He's been a great leader in the American Academy, and he's also, as you heard earlier, launched the African Otologic Society, and also he just recently launched the first Otology Fellowship in Africa. So Dr. Titus Ibikwe is a otolaryngologist and a leader in Abuja, Nigeria. He's a provost of the College of Health Sciences at the University of Abuja, and he's a professor and head of Department of Otolaryngology and Head and Neck Surgery at the University of Abuja and the University of Abuja Teaching Hospital. He's a recognized expert in preventable hearing loss and health policy, and he's currently serves as International Advisory Board Chair at the American Academy of Otolaryngology and Head and Neck Surgery. So please, Dr. Basura, Dr. Ibikwe, I will pass it over to you.
Right. Thank you, Maria. I'll say a few words and then turn over to my colleague, Dr. Ibikwe. So we're real excited. We have 4 phenomenal speakers today that's going to cover a broad spectrum of chronic otitis media. As we know, it's a spectrum of disease and brings a lot of challenges, both from management, but also from hearing restoration. So we're going to have 4 subject speakers, and we're going to address the questions throughout. So we'll remind the audience that we should place the questions that you have throughout the talks in the Q&A channels, not into the chat, and then we'll address those as we go. And then some of our speakers will try to address those that are not currently speaking throughout the talk. And hopefully at the end, depending on time, we'll be able to address those questions specifically. So really excited to get this. So we want to get right into the presentation. And then I'll turn it over to Dr. Abikwe to say a few words.
Thank you very much, Greg. And thank you, friends from all over the whole world. As we know, this is truly a global event, looking at the magnitudes of number of people from different devices of the whole world that usually key into this. Is really a time that each and every one of us look forward to. And the topic today is one that cuts across the globe, especially the developing countries, low middle income and middle income really have a fair share of the topic to be discussed today. And I believe that we're all going to enjoy every bit of this. But very importantly, I also want to remind us that nobody is too poor to give or too rich to receive. And for this reason, the Educational Trust Fund of Jim Myers is very, very important. It's part of what I showcase here in the slide, because it is through this means that we'll be able to grow the critical mass of resource persons that will manage the burden, the disease burden of chronic suppurative otitis media, which speaks for itself. The social and economic burden is humongous, and we have right mix of discussants here. So expectation is that we're going to have a wonderful day. The next slide is going to show Jim Meyer and I during my swearing in. And please, I call from everybody from every part of the world. $1 means a lot here, so that I'll be able to continue championing this cause. Thank you.
Great. Thank you, Titus. We'll go ahead and have you introduce our first speaker today, Dr. Agarwal.
Yes. Dr. Agarwal, MD, MPH. Dr. Yuri Agarwal is chair of Department of Otolaryngology, Head and Neck Surgery at the University of Colorado School of Medicine. Dr. Agarwal specializes in neurotology and is experienced in hearing loss and neurotology. Her research focuses on the vestibular system and how vestibular function changes with aging. She is principal investigator on multiple major national institutes health grants that focus on the vestibular system in aging and Alzheimer's disease. I am pleased to present to us Dr. Yuri Agarwal.
Great. Thank you so much, Dr. Abikwe, Dr. Basura, and Dr. Serna, and everyone from the AAO for inviting me to participate in this webinar. I'm really excited to see all the attendance and where they're here from. So I will go ahead and share my slides here, myself into presenter mode. So these controls here. Great. So my task to kick us off is to talk about and provide some basic definitions of chronic otitis media and mastoidectomy techniques, and mostly the definition of the disease process itself. So thank you for this opportunity, and I'm acknowledging Dr. Basura, who contributed slides to this presentation. So chronic otitis media is really a spectrum of disease, and we'll hear more about that today. So it encompasses, these various manifestations, these various levels of progression, including at some level also disease associated with cholesteatoma. So we'll go into how to categorize each of these stages of chronic otitis media. So a basic definition that sort of transcends the different stages is that it's any structural change in the middle ear system associated with a permanent defect in the tympanic membrane. And that defect often takes the form of a perforation, but also can have other defects in the tympanic membrane. And what makes it chronic is that there's a minimum of a 3-month duration of this disease process and of this structural change. There's typically concurrent middle ear and mastoid cell mucosal disease associated with this. And chronic suppurative otitis media, which is a subtype of chronic otitis media, refers to frequent or persistent otorrhea emanating through the tympanic membrane defect. So thinking about the classification of a tympanic membrane perforation, one can think about a central perforation. So I'll use my mouse here. And so essentially it involves the pars tensa of the tympanic membrane with a surrounding intact tympanic membrane. And so this is typically not associated with cholesteatoma and can be considered a safe ear. Otorrhea in the case of a central perforation can respond to ototopical drops, and also repair of this is elective. It doesn't necessarily constitute a need for repair in order to maintain a safe ear. In contrast, that could be different with a marginal perforation, which occurs at the margin of the tympanic membrane, by which the defect extends to the bony annulus, or the annular ring of the tympanic membrane. There's no remnant of the tympanic membrane adjacent to the bony wall. And this is a tympanic membrane defect that can result in cholesteatoma through the involution of skin through the defect, because there isn't a barrier of skin at the margin that prevents that involution of skin into the middle ear space. And this can be considered an unsafe ear that perhaps is more, it's more important to consider repairing these defects. Another type of perforation that we can classify as a pan-tympanic membrane perforation, really encompassing the entirety of the tympanic membrane. And so this defect extends to the annulus circumferentially. There's really a minimal remnant adjacent to the malleus of the pars tensa. Certainly, this can occur from necrotizing acute otitis media and a severe infection that compromises the entire integrity of the tympanic membrane. And this rarely develops into cholesteatoma. There's little remnant skin to seed and cause a cholesteatoma. In terms of the classification of chronic otitis media, in addition to defects of the tympanic membrane, we can also think about other pathologic changes to the tympanic membrane. And this can include atelectasis or atelectatic otitis media. And here's an example of that here, where there's collapse and retraction of the tympanic membrane into the middle ear space. And you can have a patient, Valsalva, for example, and see the tympanic membrane elevate with that positive pressure ventilation. And a PE tube can be helpful unless the tympanic membrane is too atrophic, really, to accommodate a PE tube. Another variant of a tympanic membrane defect is adhesive otitis media. And this is where the middle ear is essentially completely obliterated by a tympanic membrane that is adhesive or sticking to the entire middle ear cleft. And this can be irreversible and can make it difficult to place a PE tube because there's very little aerated space on the other side of the medial to the tympanic membrane. In terms of cholesteatoma, and this is a particular subtype of chronic otitis media can exist without cholesteatoma, and it can also encompass chronic otitis media with cholesteatoma, and that is certainly one of the feared complications of chronic otitis media. So definition of cholesteatoma is that it is keratinizing squamous epithelium within the pneumatized spaces of the temporal bone. And so, as we know, there is keratinized squamous epithelium in the ear canal in areas where it is known to be, and cholesteatoma really represents ectopic keratinizing squamous epithelium. Here's an example of congenital cholesteatoma characterized by this classic pearly mass behind an intact tympanic membrane, typically anterior to the malleus. And so this is a case where it's occurred congenitally in the absence of any necessary otitis media or other inciting events, as evidenced by the lack of any defect of the tympanic membrane. So it's remnants of squamous epithelium that stayed during development that contributed to the onset of this cholesteatoma. More commonly, we'll see in our practice acquired forms of cholesteatoma, and these have been categorized as primary or secondary acquired cholesteatoma. And primary really involves a defect of the pars tensa and the attic bone in the middle ear space, typically resulting from chronic eustachian tube dysfunction. So results in a involution and retraction progressively of the pars flaccida into the attic, but typically the pars tensa remains intact. And so that's one way to classify and note and identify a primary acquired cholesteatoma. In contrast to secondary acquired cholesteatoma, typically arises in the context of a defect of the pars tensa. And so there is a tympanic membrane perforation or defect in the pars tensa typically that results in, from an acute otitis media or from another pathologic process that results in involution of external auditory canal skin into the middle ear that results into an acquired cholesteatoma that is secondary to an infection or other pathologic or inflammatory process that's occurred. Here are different examples of what acquired cholesteatomas may look like. These are typically primary acquired cholesteatomas that, for the most part, do not involve a defect in the pars tensa. In thinking about the pathogenesis of chronic otitis media, thinking about tympanosclerosis, which is this pathologic process by which we see, typically this white scar tissue along a tympanic membrane. And this really represents collagenous deposition with calcification in the tympanic membrane following typically an infection. It's termed meringosclerosis if it's limited to the fibrous or lateralmost layer of the tympanic membrane, though it can also involve the middle ear in the form of being associated with ossicular chain fixation or ossicular head fixation, and involvement of the oval window in this case can lead to fixation of the stapes. And so tympanosclerosis refers to this calcification and collagen deposition of the tympanic membrane and also of structures within the middle ear space. So the ossicles, even the windows into the cochlea, which can lead to, in those cases, conductive hearing loss. Here are radiographic studies that are typically deployed in the diagnosis of chronic otitis media and cholesteatoma. So CAT scans are really the gold standard. And so the clinical utility provided by a CT scan is that the absence of soft tissue rules out a cholesteatoma. So soft tissue really is the pathologic hallmark of a CT scan. It doesn't necessarily indicate that it's a cholesteatoma, but in the absence of that, it's likely that there is not a cholesteatoma. Soft tissue and bony erosion correlates with cholesteatoma. Cholesteatoma does not enhance with contrast on CT scan. And as mentioned, CT does lack specificity in terms of differentiating cholesteatoma from other soft tissue processes. So fluid from an obstructive mastoid, post-obstructive fluid accumulation, mucosal disease. And certainly if there's intracranial tissue involved, you would need to see, for example, in this case with an MRI to better define whether that represents cholesteatoma or another type of pathologic process. Here's an example of an axial image. And really, CT scans are indicated, many of us do them routinely in the context of preoperative evaluation for chronic otitis media, but certainly, these are indications that I think we would all agree a CAT scan is necessary. So in revision surgery, certainly if one may not have participated in the original primary surgeries when the anatomy is unclear. In the case of congenital ear malformations. In the case of clinical findings that may indicate more advanced disease that would merit a cholesteatoma, facial nerve paralysis, or a suspected CNS complication. And finally, here's an MRI scan that also shows fairly nonspecific findings in chronic otitis media. Again, post-obstructive fluid can be seen. Gadolinium does enhance the matrix and other inflammatory changes. MRIs could be are very useful in the definition identification of intracranial complications. So, for example, in the case of abscesses or sinus thromboses that may occur in the context or as a complication of a chronic otitis media. So I will stop there. Thank you.
Great.
Thank you very much for the beautiful presentation. I hand over to Greg to introduce the next presenter. Please, our listeners and colleagues, drop your questions in Q&A. Don't do that in the chat. It will get lost there. Thank you.
Great. Thank you, Titus. Thank you, Yuri, for that wonderful setup for the rest of our talks here. So I'd like to introduce Dr. Durr, Carolina Durr, while she's uploading her talk. Dr. Durr is a medical officer in the Department of Non-Communicable Diseases at the World Health Organization in Geneva, Switzerland. She works within WHO's Department of Non-Communicable Diseases and specializes in ear and hearing care research and policy. Dr. Durr's work focuses on global health initiatives and addresses hearing loss at major public health as a major public health challenge. Her research includes work on perceptions of hearing loss and hearing technology among the general public and healthcare providers, as well as studies on service delivery approaches for hearing aids in low and middle income countries. So it's my privilege to introduce Dr. Durr. Carolina will have you take it away. Thank you very much for being here.
Thank you, Greg, for the invitation. Thank you, everybody. I'm glad to be here with you in a rainy day in Geneva. I have a little problem with my slides because when I put them in presentation mode, they disappear for me. I don't know why exactly, but I will present not in presentation mode if that is okay for you. You let me know if you are able to see my slides. Okay.
Not yet. There we go. Looks like they're coming up.
Okay, so I will go this way because if not, they disappear. Sorry about that. So, well, today I'm going to speak about a condition that is part of the chronic otitis media spectrum, which is cholesteatoma. As Yuri said, is mostly a complication, but a very important one, and probably for otologists, is the main issue we want to avoid in relation to a patient with otitis media. So, can you see the second slide?
Yes.
Fantastic. So this is the nightmare for an otologist. This is a case of a cochlear implant patient that developed afterwards a cholesteatoma. I have to say it's something nobody wants to have in their hands, but it reflects very well the importance of the condition, the cholesteatoma itself, and also the relevant part that is to being able to preserve and or rehabilitate hearing loss after the eradication of the cholesteatoma. The main factors here is that cholesteatoma represents a progressive bone erosion in the mastoid, in the ossicles, and could lead to permanent hearing loss. So I'm not going to talk about mastoidectomy because you will have a great presentation after this one. So I'm going to jump to the hearing loss rehabilitation. And always the first step is counseling. And the counseling is related to the options the person have for rehabilitate their hearing loss. And that will depend on the type of surgery that was needed in that case. Canal wall up or canal wall down is completely different. If there is a very extensive ossicular damage or not, if that person have any risks of infection, and of course the timing of fitting, because sometimes you need to wait until the surgery is completely healed, and to make sure that there is not a recurrence and also infection related after the surgery before you plan for a fit. Well, when we talk about hearing loss rehabilitation, the first option is the surgical reconstruction. So when we address a cholesteatoma, the main issue is to eradicate the cholesteatoma. Then the second point is to prevent recurrence. And the third point is to try to preserve hearing, or if you are not able to do that, rehabilitate that. So for rehabilitation, and I will open a little here the spectrum to otitis, chronic otitis media in general, the main surgery is tympanoplasty. In tympanoplasty type 1, you just repair the tympanic membrane with a graft of cartilage or fascia. And then from type 2 to type 4, you need to include ossiculoplasty. And the classification is from type 2, when you have only the malleolus damaged, to type 4, when you have only the platina to put your graft there. And you can repair with an autologist material like cartilage or fascia, or heterologist material like titanium or hydroxyapatita. And you can use TORPs and PORPs, partial prostheses that cover part of the ossicles, or total prostheses to repair that. The objective here is to being able to preserve the function of the ossicles and be able to restore hearing loss. Then you need to think about if you are going to do one step or two steps surgery. You can do in a first step the surgery to eliminate the cholesteatoma, make sure everything is fine at that aspect. And in a second step, you can repair the ossicles and make a tympanoplasty. And also, you need to consider if you have a canal wall up or a canal wall down in terms of your planification of reconstruction of that ear. I will talk very, very briefly about devices. So, because you will have a very detailed presentation about this at the end. But you need to consider that hearing loss after cholesteatoma is in general conductive, moderate conductive hearing loss. So if you are able to use a hearing aid, that's probably the first option. You will need probably an ear condition that allowed you to do that. Let's say a canal wall up surgery with a tympanic membrane intact. That's the best scenario. And if that is not the situation, but you have a good result, remember to use ventilated molds or open feet for these patients. The other option is bone conduction, non-implantable. Well, we have different systems here that you can suggest depending on the age of your patient or the situation of the ear. Then we have the bone conduction implants. Here you will have better results in terms of hearing. I'm showing here two devices that are transcutaneous active devices, which is the top technology for these devices nowadays, but there are other options also to consider. Finally, cochlear implant. This is not something we do frequently when there is otitis media in place, because as I said, majority of them will have conductive hearing loss. But in some cases, you may have sensory neural hearing loss related to the otitis media. And in that cases, you can plan on a cochlear implant. And it's very complicated in terms of cavities because you need to cover your implant, and that's also a challenge for otological surgery. So, as Greg said, I work at WHO. So I want to give you some feedback or information about what's WHO doing related to otitis media and, of course, cholesteatoma. We are working in this document, in this tool. The name is Package of Ear and Hearing Care Interventions. Some background. Why are we going to do this? Because over 430 million people live with disabling hearing loss, majority in low and middle income countries, and we know that the interventions are out there, that they are effective in terms of treat persons and of course, rehabilitate hearing loss, but they are not accessible and available in low and middle income countries. So this document, the objective is to provide ministries of health with this document that is evidence-based, that identify the interventions the ministries of health need to have available for people in order to cover the needs of the ear and hearing care programs. So what we do is give technical guidance and evidence-based recommendation on the main ear conditions, what workforce competencies are needed, which equipment and medicines are needed, and also which kind of assistive technologies are needed to be available in every country. And after that, we identify in which part of the health system these conditions have to be available, primary, secondary, or tertiary level. For example, a cochlear implant surgery should be at tertiary level, but for example, a diagnostic otoscopy should be in all levels. How do we do this kind of work? Well, we start selectioning the main ear and hearing conditions that must be addressed. We do that based on prevalence and impact. Then we identify a group of experts that will collaborate with us, and also a group of researchers that will collaborate with us. The researchers will do the literature reviews, and the technical experts will participate in the approval or not of that results before we go to the next step. And once we identify the evidence-based intervention from high-quality guidelines and systematic reviews, and the experts approve, then we go to our document and present it as it is. What's happening with cholesteatoma? First of all, to let you know that otitis media is, of course, one of the conditions we are addressing, acute and chronic, but I will show you today some preliminary results about cholesteatoma. In the case of cholesteatoma, we didn't find high-quality guidelines, so we need to do an umbrella review. After that, we evaluated the quality of the different reviews identified with the tool AMSTAR 2, with 2 independent reviewers. So here you have the selection of the different papers for you to know. At the end, we got 10 papers that were valuable for this work. And this is the way you are able to evaluate the documents using the AMSTAR 2. So as a teaser, from now, in terms of diagnostic for recurrence, the non-echoplanar diffusion weighted imaging, MRI, is very useful according to the evidence. For management, and this is an introduction for the next presentation, is efficient canal wall down mastoidectomy, mastoid obliteration, and they recommend also endoscopic ear surgery associated to have lower recurrence and better outcomes. And finally, there are subgroup of interventions that must be considered as a part of the possibilities in cholesteatoma, and that is tympanoplasty, ossicular reconstruction, and labyrinthine fistula management when that is the case. So I will stop sharing here. Thank you very much, and back to our moderators.
Thank you, Carolina, for that. Really appreciate it. So just to note to everyone, please put your questions in the Q&A, and our authors or our presenters will address those as we go. And I'll turn it back to Titus to introduce our next speaker. Titus, I think you're muted.
Thank you very much, Greg. I'm glad to present the next person to give us talk on this very important topic, all the way from South Africa, Dr. Tashneem Harris is a consultant otorhinolaryngologist in the division of otolaryngology at Groote Hospital, University of Cape Town, South Africa. Dr. Harris is a recognized leader in otology and cochlear implantation in Africa. She co-founded the Otology Fellowship at Groote Hospital, University of Cape Town, which in 2022 became the first such fellowship in Africa. Her research and clinical interest focus on hearing loss and cochlear implantation, particularly in resource-limited settings. Dr. Harris has extensively studied barriers to cochlear implantation in low and middle-income countries, addressing challenges such as lack of neonatal screening, device costs, limited rehabilitation services, and shortage of trained personnel. Over to you, Dr. Tashneem Harris.
Thank you very much, Titus, and thank you very much for that very kind introduction. Good afternoon or good evening to our listeners. I've switched my video off because my internet connectivity is unstable. So I'm going to be looking at mastoidectomy techniques, and I'll head into my talk. So the indications of mastoidectomy, this is just a slide which looks at the various indications. It's by no means a comprehensive list. And we're looking today at chronic otitis media. So right at the top is obviously the most common one, which is cholesteatoma, but it's also performed for various other reasons like cochlear implantations, repair of temple bone CSF leaks, and it's an initial step in lateral skull-base surgery for tumors. Now, I think this is quite an important slide. And it's important because when one thinks about cholesteatoma surgery, it's not just the eradication of disease that is the aim of the surgery. It's also improving middle ear ventilation. It's trying to prevent recurrent disease, and also creating a dry self-cleansing cavity. Now, your patient comes to you with an ear that is leaking, and surgery that is not performed properly leads to a wet cavity. And so for the patient, you haven't really changed the fact that the ear is leaking. And this is something that really needs to be addressed when you're looking at your surgery. And then obviously the secondary aim is reconstituting the hearing mechanism. There are different types of, this is looking at microscopic mastoidectomies, and there are different types. There's canal wall up or canal wall down, which really depends on whether or not the integrity of the posterior canal wall is intact or it's taken down. And it goes by various names, depending on your institution or depending on the literature. But essentially, a radical modified open technique refers to canal wall down mastoidectomy. And then canal wall up can be referred to as combined approach or closed technique. Now, the indications for wanting to do a canal wall up versus canal wall down is quite nuanced. It's going to depend on the extent of the disease. It depends on the pneumatization or the ventilation of that ear, and that really speaks to the risk of that disease coming back, the risk of recurrence. And for very large cholesteatomas, there's a more likelihood of actually taking the canal wall down. Or if there's been previous complications, there's the likelihood of taking that canal wall down becomes higher. But one also takes into account the compliance of that patient with regards to follow-up. Now, this would not be a complete talk without mentioning endoscopic approach. It's been in the literature for the last 20 years, looking at both. And I think we've got sufficient data out there to validate this as an approach to cholesteatoma or mastoidectomy. And microscopic approach, as I've said before, can be divided into canal wall up or canal wall down. And likewise, the endoscopic approach have used sort of similar rationale for a classification of their different approaches, which is either endoscopic transcanal management, that's for very limited disease, or endoscopic open cavity management, where one has to remove bone, or an expanded transcanal approach. And this is an algorithm really which looks at the endoscopic management of cholesteatoma. And essentially one starts off looking at the adequacy of that ear canal. So either you have an adequate ear canal or it's not adequate. And that really refers to the access of getting the endoscope in there. When you've got accessible mastoid disease, and that really refers to does extend beyond the otitis ad antrum, you can remove the cholesteatoma with a limited approach. When you've got inaccessible mastoid disease, so it's going beyond that into the mastoid, deciding whether or not the status of mucosa, aeration of the mastoid, has the patient had previous surgery, and you may need to either do a post-auricular conventional mastoidectomy or stay with the endoscopic approach. And likewise, when the ear canal is inadequate, using an expanded canal access follows a similar algorithm. It's either accessible disease or inaccessible disease, and that determines whether or not you need to go to an open approach or whether you can stick with an endoscopic approach. What it really boils down to is, and this was the rationale for endoscopic ear surgery, is that there are hidden areas in the middle ear. And even as a microscopic ear surgeon, I can concede that with a microscope, there's a very direct view of that middle ear, and that there are some areas that remain inaccessible. With the endoscope, the advantage of the endoscope is that within the middle ear, you have enhanced visualization and also an expanded view that allows those hidden areas to be visualized properly. And those hidden areas are the anterior epitympanum, the facial recess, sinus tympani, and the hypotympanum. Of those, the only one which is can still be hidden, whether you do a canal wall down, is going to be your sinus tympani. And I find this classification quite useful. It's Marchionne's classification of sinus tympani anatomy, which refers to whether that sinus tympani extends beyond the level of the facial nerve, or posteromedial or posterolateral to the facial nerve. And that really is going to determine whether or not you can reach it with the microscope, or whether you need to bring in an endoscope as an adjunct to remove residual disease. Now, I think we can safely put the debate of endoscopic versus microscopic mastoidectomy to rest, and say that there's definitely a role for cholesteatoma, for endoscopy in cholesteatoma management. We realize that even with a microscope, these hidden areas are not accessible. Endoscope is a very useful adjunct, particularly for those hidden areas. It reduces the residual disease in the canal wall up and can prevent you from actually, prevent you from going down to a canal wall down procedure if you wish to keep the canal wall up. However, endoscope has not eliminated residual disease in the sinus tympani, and this is quite important. And so in our institution, for those people that have had endoscopic removal of the cholesteatoma, we still follow them up as for canal wall up mastoidectomy. I'm not going to go into the preoperative considerations in great detail, except to say that clinical examination is obviously important, having a hearing test to determine what the hearing is like, confirming that with your tuning fork tests. What I'd like to underscore here is the importance of reliability for follow-up, because in your resource-limited areas, or where patients, for either geographic or economic reasons, have poor access to healthcare, it may sway your decision to do a canal wall up or canal wall down. Imaging is always useful. It's not always available, but always useful to determine the extent and to plan your surgery. And obviously, the discussion with the patient of the risks and the benefits of that surgery. Now, the CT checklist, we all know it's looking at the pneumatization, ventilation, the ear canal, the patency of the ear canal, the size and the access of the ear canal, status of the ossicular chain. Tegment tympani is quite important, because if you've got a very low-lying tegment, that can make a canal wall up mastoidectomy very difficult, and one might have to do a canal wall down mastoidectomy. But also whether or not the tegment is dehiscent or not, because those are the structures that you want to preserve are obviously the dura and the facial nerve, and whether or not it's dehiscent or covered by bone. You want to visualize and assess whether there's a lateral canal fistula. And then venous structures like the size of an emissary, as bleeding from the emissary vein can cause you to stop your surgery if it's excessive. And then the sigmoid sinus and the relation to the mastoid cavity, and as well whether or not it's dehiscent. So sigmoid sinus that is very anteriorly can make it very difficult to keep that canal wall up. And in addition to that, jugular bulb and whether or not it's dehiscent. Now, the instrumentation and positioning is important, and I'm looking here and talking specifically about microscopic ear surgery. Just see if I can get that out of the way. One should never lengthen a cutting burr. And the reason for this is the minute you lengthen a cutting burr, it jumps when you start using the drill. You can only lengthen a diamond burr, that's absolutely fine, but cutting burr should be used at a short length. The other thing to consider is the position of the head, and the head has to be in a neutral position. It has to be rotated, obviously, depending on the ear that you're operating on, but this is neutral position, but not tilted. So never use a head ring or pillow underneath the patient's head. This not only ergonomically is not good for the surgeon, but also actually doesn't allow you to see into the ear and see into the epitympanum adequately. So there are different surgical approaches that you may use. It can either be an in-oral or post-auricular, and either of those are adequate. Canaloplasty and mastodectomy is quite an important topic. So cholesteatoma, as we know, may be in very hard to reach places. If you're going to keep that canal wall up, it may be very difficult to visualize certain areas in the middle ear. And doing a canaloplasty, particularly if you're looking at in the hypotympanum, allows you to visualize the middle ear properly. It may be important for tympanic membrane grafting, particularly where you've got tympanic membrane perforation that's going anterior superiorly. And then a narrow ear canal can affect the ventilation, even in canal wall down mastodectomies. And I'm going to touch on this in one of my later slides. Now, the landmarks of mastodectomy, we know you've got the tympanomandibular joint, which is anteriorly the root of the zygoma. Suprameatal spine is something you want to identify when you're doing your soft tissue work, always palpating the mastoid tip. McEwen's triangle is obviously also something that you identify once you've elevated your periosteal flap. And essentially you want good exposure and good soft tissue work so that you've got those bony landmarks in view. When you start your drilling in open surgery, the principal landmarks here are the linea temporalis, the bony ear canal and the spine of Henle anteriorly, and palpating your mastoid tip inferiorly. The line of drilling is your linea temporalis, and skeletonizing the dura and identifying the dura along the linea temporalis. And the other important thing is drilling techniques. And I have to say here, for me, having a good drilling technique is as important as having a good knowledge of temple bone anatomy. This is just a video which shows the drilling techniques. And here you can see the mistake here is leaving that cutting burr quite lengthy. That video was slowed down, so you couldn't see a jump. The second mistake is drilling, but not drilling and suctioning at the same time, mainly because the irrigation is not pointing down to where your drill is. And here you can see it's kind of like a swiping technique where half of the time the drill is up in the air and the other half it's actually on the bone. What you want to do is have the irrigation face the bone while you're drilling, use an appropriate size burr, use an appropriate size suction, keep contact with the bone, make sure that you suction at the same time so that you can identify color changes as they occur. Sorry. Now, finding the mastoid segment of the facial nerve is quite important. And the way to do that is actually identifying the tegmen and identifying the sigmoid sinus posteriorly, and following that tegmen medially, identifying the short process of the incus and lateral semicircular canal. And those are very useful landmarks defining the initial part of the facial nerve in the mastoid. You then start thinning the posterior canal wall, identifying the digastric ridge. And the facial nerve, as you start thinning down the posterior canal wall, you see these periosteal fibers, and these are the periosteal fibers of the stylomastoid foramen. And here you can see the facial nerve very reliably if you drill in a parallel line between the lateral semicircular canal and where the digastric ridge is, the facial nerve will come into view. Now, a very useful way of finding that as you're drilling is identifying this, which is the sensory branch of the facial nerve, which seems to be fairly consistent in terms of its landmark. Chordae tympani may vary in terms of where it takes off in the mastoid segment, but the facial nerve, the sensory branch, is always reliable and remains the same. Facial nerve monitoring, just a word on that, is not a substitute for knowledge of anatomy or surgical skill or clinical judgment. But it is very useful when the nerve is obscured by pathology. And the facial nerve in very long-standing chronic otitis media may appear just as granulation tissue. But it is surgeon dependent. And some surgeons like to use it, some don't. And that really is entirely up to the surgeon. Now, the advantages of canal wall up mastoidectomy are rapid healing time. It's easy in terms of long-term care. Hearing aids are easier to fit, and there's no need for water precautions. The disadvantages is that canal wall up mastoidectomy may be technically more difficult. There's a high risk of recurrent disease, and one may need to stage the operation, particularly if because of the risk of recidivism. And residual disease may be harder to detect here. In canal wall down mastoidectomy, you've got improved visualization, much lower recurrence rates. The disadvantages are that there's a need for regular cleaning. There's an increased risk of infection and water precautions, and the patient's committed to long-term outpatient care. Now, there are problems with open cavities. One is chronic otorrhea, dizziness due to caloric effect, the dependence on the surgeons for regular cleaning of that cavity, and the persistence of otorrhea in mastoid cavities may be due to various different reasons. It may either be due to a high facial ridge, or there's a very large cavity. Even if it's well epithelialized, having a large cavity can leak. If there's an inadequate meatoplasty, or the presence of a tympanic membrane perforation, or there's inadequate clearance of disease. Now, this is a schematic diagram showing an axial view through the middle ear and mastoid. Below, you can see a very, very prominent anterior bony overhang, a very high facial ridge, inadequately saucerized mastoid cavity, which leads to a very deep mastoid cavity here, and this leads to retention of debris. Essentially, what you want is a small cavity which is well saucerized, an adequately lowered facial ridge, and an adequate meatus for drainage. Meatoplasty is an integral part of canal wall down mastoidectomy because it improves your access for cleaning and ensures adequate ventilation. But it's beneficial there should be in canal wall up mastoidectomy if that lateral canal stenosis is present. So the strategies for minimizing risks when you're performing mastoidectomy really are a preoperative assessment and a high-resolution CT scan to assess the anatomy and variations thereof. And then intraoperative, having a really good surgical technique, identifying critical structures, maintaining good hemostasis, a good drilling technique, and using the appropriate burrs and instruments. Thank you very much for your time.
Tashneem, thank you very much for doing justice to this beautiful topic and making it so practical. Thank you. May I also use this opportunity to make an appeal to all the members to drop your questions in the Q&A box so that I'll be able to have an access. Thank you. The next presenter will be presented by my colleague, Greg. Over to you.
Great. Thank you, Tashneem. Thank you, Titus. For our last speaker of the session, I'm honored to introduce Dr. Stefan Plontke. Dr. Plontke is professor and chairman of the University of Otolaryngology Head and Neck Surgery, Department of Halle, Germany, and member of the Presidential Council of the European Confederation of Otorhinolaryngology Head and Neck Surgery. And he served as conference president of the CEORL Congress in 2028 in Berlin, Germany. He's a member of the Collegium ORL-HNS, member of the board of directors of the Prosper Meunier Society, and member of several editorial boards. His clinical research interests focus on otology, neurotology, and lateral skull-based surgery, middle and inner ear surgery, including cochlear implantation, sudden hearing loss, and drug delivery of the ear. Dr. Plontke, it's great to have you. We can go ahead and have you upload your slides, please.
Yeah, thank you very much for the kind introduction, and good morning, good afternoon, and good evening to our colleagues throughout the world. I'm absolutely thrilled when I saw on the chat who is saying hello and who is here from so many parts of the world. These are my disclosures. I'm coordinating investigator of several clinical trials, usually with sudden hearing loss, involving sudden hearing loss drug delivered to the inner ear or implantable hearing devices. I'm very proud that I can be part of this webinar here. I'm related a little bit to chronic ear surgery because Halle, this is a very old university, the first ear hospital in Germany. And there was always a center of ear surgery, starting with Hermann Schwarze, who in 1873, so more than 150 years, with his landmark publication about the artificial opening of the mastoid process, showed the technique of mastoidectomy, showed the clear indication criteria, and actually had the first clinical trial in a way of a large case series. It was already mentioned that for hearing rehabilitation for chronic otitis media, we have to remember that although we almost have a solution for every kind of hearing loss now, that a sufficient surgical treatment of chronic otitis media, meaning tympanoplasty and a conventional hearing aid if necessary, is always the primary option. So we should remember a good ear surgery, decent ear surgery, and if necessary, conventional hearing aid is the best option. Conventional and implantable bone conduction devices and active middle ear implants are indicated if cases of conductive and mixed hearing loss and chronic ear disease that for audiological or medical reasons cannot sufficiently treat it with surgery and hearing aids, but which is not the indication range for the cochlear implant yet. And cochlear implants, the indication range of core as in cochlear implantation, and here the precondition is, of course, a sufficient surgical treatment of the chronic otitis. We have heard talks about mastectomy and tympanoplasty and passive prosthesis, and I will mainly talk about these conventional implantable bone conduction devices and active middle ear implants. This is an overview over the approved systems. And so we have quite a variety, and as Professor Jacques Zahid from London once put it, we have an implant for every season. So we have the conventional bone conduction devices, the implantable bone conduction devices, and active middle ear implants. And they are basically differentiating from each other by the coupling site, so either skin or skull bone or middle ear and cochlea. And then they're different in the energy transfer from the processor to the implant. This could be percutaneous mechanical, transcutaneous magnetostatic, or transcutaneous electromagnetic. And then they are different in the energy transferred and the actuator technology at the coupling side, which could be passive mechanical, passive magnetostatic, or active electromechanical, or active piezoelectric. The choice of a device or an implant is a complex decision. Of course, from an audiological point of view, we want an optimal audiological solution with respect to hearing loss, technical device-related parameters, and expected coupling efficiency. But also we want an optimal surgical solution depending on the pathoanatomical aspects, the device dimensions, and the coupling side. And then there are other patient factors, patient wishes and expectations, social aspects, device usability and connectivity, and of course, different reimbursement issues throughout the world. Let's start with the optimal audiological solutions. What do we want? We want not just hearing something, we want an effective dynamic range of a device. So we have a device with a maximum power output, so a certain force of the device, but we want to end up with a potential good audiological result. We have to remember the dynamic range of speech is about 70 dB. And for a good speech intelligibility index, we need a dynamic range of about 30 to 35 dB. If this is less than this, we don't have a good hearing outcome. And there are several factors influencing the effective dynamic range. So the maximum power force of an implant is reduced by the feedback. So we have to consider the feedback-free gain of a device. Then each device has a noise floor. That results in an intrinsic dynamic range of a device, which is definitely smaller than the maximum force the device can produce. Then, of course, the patient has a sensorineural hearing loss, usually at least. In an active middle ear implants, we have a transfer deficit by coupling efficiencies or differences in coupling efficiencies. And since active middle ear implants involve a manipulation of the articular chains in the middle ear space, there's a possible bone conduction deterioration during surgery. For bone anchored hearing devices, at least in very asymmetric hearing thresholds and inner ear hearing thresholds, bone conduction thresholds, we have to consider impairment by contralateral routing of sound. And then over the years, we have a deterioration of bone conduction after surgery. So what is the feedback-free gain? So acoustic feedback possibly occurs due to the proximity of the actuator on the microphone. And this is critical for headgear, for instance, or in reverberant rooms, for large amplifications, meaning for very poor bone conduction thresholds. And it's, of course, worst for the bone conduction system. It's not a problem with a digital signal transmission system like a cochlear implant. So here we have a reduction from percutaneous through transcutaneous devices. It's not so a problem for the active middle ear implants, and again, no problem for the cochlear implant. Coupling efficiency. So how effectively do we get the energy into the inner ear? And this is important because there might be deficits for certain couplings in the active middle ear implants. Then we have considered energy transfers through the screws in the bone bridge, for instance, or implant contact in sentia. And then also we should not forget the inductive coupling through the skin for analogous devices. So coupling efficiency here, especially for the active middle ear implants, we have a small floating mesh transducer that is directly coupled to the middle ear inner structures and needs to transfer the energy. And in order to transfer the energy to the middle and inner ear, different couplers have been developed for forward coupling through the stapes or stapes footplate, or a backward reverse coupling through the round window. And that has been extensively investigated during the last years. And it has been shown that the coupling efficiency and postoperative word recognition depend on the surgical methods, the coupling site, and the coupler. So we do have to consider the coupling efficiency in certain surgical methods. We have to be careful if we max out the bone conduction indication limits, especially for the active middle ear implants. But there is light at the end of the tunnel. We can actually measure coupling efficiency intraoperatively now and look whether we have a good coupling. Also, coupling efficiency plays a role in the speech processor. So the efficiency of coupling decreases with coil distance, meaning with the thickness, and this could be as much as 1 to 3 dB per millimeter efficiency loss. And again, this plays a role when we max out or when we go near the indication range of the devices. And then when we do surgery, we have to also consider that there is probably an optimal retention force of the magnet of 0.2 to 0.4 Newton, getting a good balance between skin complications and the processor falling down. As I mentioned already, for bone conduction devices, we have to consider crosstalk. If we fit an ear with a bone conduction device with a very poor bone conduction threshold and the other side has a normal threshold, we usually cannot crank up the device as much as we would to get the amplification, to get the gain, because we have crosstalk to the other side that will influence speech understanding and also directional hearing. So if we summarize this, if we look at the limits due to the bone conduction threshold, the sensory hearing loss, and then the maximum power output of a device, we get this maximum possible dynamic range. And if we aim for a 30 to 30 dB dynamic range for a good speech intelligibility index, the red line would now indicate the parameters that are necessary in the devices. So if we look, for instance, at the percutaneous bone conduction systems like the Baha 5 superpower or the 3 superpower, we get a limit for the bone conduction of about 55 to 60 dB. If we look at transcutaneous systems like the OSIA, the bone bridge essentio, or the Phono, we get smaller maximum limits for bone conduction of a bit between 35 to, let's say, 55 dB. This, I will not question you on this in the at the end, but there are tables that you can look up what kind of devices will give us what minimum threshold that we have to look for in order to get the 30 or 35 dB dynamic range. Now let's look at some aspects of optimal surgical solutions. I only have a selection here, of course, due to time reasons. Let's start with the more classical and initial percutaneous mechanical devices. This is the Baha Connect. It's a titanium implant with osseointegration, but the abutment is through the skin, so percutaneous. And then very similar, the Ponto, also with an abutment through the skin, percutaneous external audio processor for children and adults as the Baha for conductive and mixed hearing loss. The largest critique or the largest disadvantage of these devices, although there have been a lot of improvements over the year, is that we have a lesion in the skin. Basically, the implant itself penetrates the skin. Then the transcutaneous electromagnetic devices, bone bridge and Sentio, with the introduction of the neurodevelopment, the BCI 602, we could show that it now fits in most of the skulls, even for smaller children from 3 to 8 years. And here the energy transfer is through the screws, through the screws at the wings of the implant. So it's very important that the wings are flat on the skulls and the screws are tight, because that's where the energy is transferred through the skull. There is a certain distance or thickness to the implant. And for small children or children with malformations, for instance, we have to be careful and not to damage, for instance, the sigmoid sinus, but there are surgical techniques described where we can hold up down the surgical, the sigmoid sinus with a little bone island, for instance, during surgery, and then without danger implant the device. It needs to be mentioned that due to the force and torque neutral magnet technology, these implants are now MR capable. So there's an MR, a magnet shadow, of course, but we can go into the MRI with it. The other transcutaneous electromagnetic implant is the Sentio, and here it's even flatter. So the footprint is flatter in the skull, and we could show that almost everyone can be fitted regardless of the skull thickness. Of course, there's always exceptions with this implant. Here, the energy transfer is different. The implant is fixed with a fixation band. And it's important that the implant body, so the mass transducer body, is lying flat on the bone. So it must not be in the free air, because the body is actually transmitting the energy. The wound closure in both implants, the incision is small, and both in the bone bridge and in the Sentio. Now we go to the Ossia implant. There's also a titanium implant. Here, the specifics is that the implant is osseointegrated. We have also an inductive energy and data coupling. And we have a piezoelectric actuator, not an electromagnetic actuator, which gives us especially a larger gain in the high frequency. So it's a more powerful bone conduction, transcutaneous bone conduction implant, especially for the high frequencies. Here, this is from the manual, but we have to note that we should not, the implant should not lay flat on the bone, because the energy transfer is through the central of the implant, and the actuator must not touch the bone. Actually, we usually drill a bed, the actuator, the piezoelectric driver, in order to produce the force, needs to be in a distance from the bone. And this can be neatly tested, for instance, here intraoperatively with the bone bed indicator and the pin and the body. If you drill a bed and then put in the implant, and then you can look with the bone bed indicator whether there's enough space for the piezoelectric driver to actually develop its force. The incision for the Ossia is larger than for other implants. This is the incision I use, the full line here over the neck of the implant. Nevertheless, in careful surgery, the cosmetic outcome is still good, and I'm surprised how good it is. To finish up, again, the active middle ear implants, just one example, the transcutaneous electromagnetic implant, the sound bridge. Here again, different coupling options, but it also shows there's different options for different situations, a lot of solutions, but all surgically challenging. And to summarize my talk, the first choice, again, for hearing rehabilitation in chronic otitis media or cholesteatoma is tympanoplasty, and if necessary, a conventional hearing aid. That's always the first choice. The conventional implantable bone conduction devices in active middle ear implant should not be considered a replacement for good classical middle ear surgery or tympanoplastic procedures. But they result in very good outcome if indicated and appropriately selected. Selecting an appropriate device for an individual patient is often a complex decision. To achieve a sufficient effective dynamic range in the end, many factors, device and patient-specific factors must be considered. We have to be careful when we get close or even exceeding the advised bone conduction threshold. So I would personally try to not max out the indication range that is provided by the manufacturers. And considerable possible loss of energy through poor coupling in active middle ear implants, but also bone conduction implants. And also consider other aspects like MRI compatibility and surgical complexity, as for instance in active middle ear implants. And of course, consider cochlear implants when the cochlear reserve is too poor. Sometimes it's better to not have a poor result with an active middle ear implant, but sometimes the step to cochlear implant is the right. I would like to acknowledge our head of audiology, Professor Thorsten Rahne. Again, I would like to invite you to Gothenburg in April next year, and a little time later than in Berlin in 2028. I would love to see you there.
Great. Thank you, Dr. Plontke. That was fantastic. I'd really like to thank all of our speakers today. These were very informative and really great talks. Thank you very much. I think we have a few minutes here to address some of the questions in the chat or in the QA. So maybe I'll throw a couple out to the panel here. Someone asked at the very beginning, how do you differentiate acute mastoiditis from simple glue ear in a CT or on a CT? I frequently get quote unquote otomastoiditis in CT reports where there is no sign of mastoiditis clinically. I think that's a common problem we all feel. Any thoughts on that from the panel? I'll open that up. Dr. Agarwal, what do you think since you opened up first?
Yeah, so I agree that I get those reports also. I mean, I think mastoiditis, also is a clinical diagnosis. And so, I think, a typical feature that you'd see on a CAT scan is evidence of bony erosion that would distinguish it from glue ear. And so I think that's typically the radiographic finding that shows a clinically significant mastoiditis from, post-obstructive fluid, which you can get with a glue ear. So I think, largely as a clinical diagnosis, I would place a 2, probably see if that can drain the glute ear, and then observe the patient clinically, unless there is evidence of, more broader disease, including, post-auricular edema, radiographic evidence of mastoid erosion, et cetera.
Great, thank you. Carolina, did you have a comment?
Yeah, it's very common to see in the radiologist report mastoiditis, and I totally agree with Yuri. It's a clinical diagnosis. You can see this mastoid full of glue ear or any liquid, but what you see in the patient is the important part, not just watch the image and watch the report of the radiologist.
Mm-hmm. Another question here, and I'll turn it to Titus to address a couple other questions, is, does anyone have experience with the management of tuberculosis otitis media? Can I wall down as surgical management with anti-TB medication times 6 to 9 months? ? Tashneem, I know you've seen TB quite a bit in South Africa. Do you want to comment on that one?
Yes, thank you very much. So TB responds really well. TB, if it's rifampicin sensitive, responds really well to tuberculosis medication. The problem with doing a mastodectomy, I would never do a canal wall down mastodectomy. The patient will end up with a refractory leaking ear and need a subtotal petrosectomy eventually to stop that ear from leaking. The TB medication is effective. If you find that it's not responding to the usual TB meds, you may be dealing with a resistant bug. But it responds really well to TB meds. Yeah.
Great, thanks, Tashneem. Titus, I'll let you ask a couple questions there, please.
Very well. Thank you very much for the great responses. We still have more couple of questions here. Very interesting. This comes from Emily, and is there a role of eustachian tuboplasty or balloon dilatation of the eustachian tube in the treatment of chronic otitis media or in post-operative management of chronic otitis media / cholesteatoma? I want Dr. Agarwal to take
I answered a kind of a similar question. I think that that definitely is a common question that comes up. There's no real guideline, to determine your clinical consensus around, the context in which to use eustachian tube dilation. I've, had a patient ask me after we did a tympanoplasty, why don't you do that? And so I think that's given me, some sense of, thinking about where it is in the algorithm, both in terms of primary tympanoplasty, but certainly when considering, revision tympanoplasties. I think often, if there is a post-tympanoplasty failure, that can be in the context of persistent eustachian tube dysfunction. And so, I certainly consider, if I'm considering a revision, whether or not I would also do a eustachian tube balloon dilation concurrently. And so, I would discuss that with the patient. I think I wouldn't go and do a revision surgery without, considering that and talking to the patient about it. I think it is challenging. I think there are other indications where if you're doing a tympanoplasty in the context of mastoidectomy, cholesteatoma eradication, et cetera, as a primary procedure, would you consider doing a balloon dilation at that point? Because some of it can be, some of that disease process can be in the context of eustachian tube dysfunction. So, I think it's reasonable to consider doing that. I think it's something to, involve the patient in decision making, but I think it makes sense based on the pathophysiology to consider it.
Brilliant. Stefan, what's your take on this?
Yeah, we had this question also for many years, and we some weeks ago we published a randomized controlled trial in JAMA Otology on this, and found out no difference at all between the two groups, either with patients scheduled for tympanoplasty and where we did a balloon dilatation or where we did not. And our conclusion was that we think there's so many factors that are responsible for the disease that we have to really find the group probably where the eustachian tube dysfunction is the most or the the only or the very important contributing factor. Otherwise, well, what you definitely don't do anymore is like do it as a standard procedure in every one of these cases where the data don't really speak for this. I think there's some hints or there's some evidence for like adhesive otitis media or retraction things when otherwise the mucosa is normal, for instance.
Tashneem, any addition to this?
Yes, so I don't have any personal experience with eustachian tube dilation. But I do think, I think if there's underlying sinus disease, treat the sinus disease. That's the easiest one to deal with. So, in terms of eustachian tube dilation, I don't think I've come across any studies to show that makes a difference in chronic middle ear surgery, but definitely make sure that if there's allergic rhinitis, make sure that the person's treated. If there's enlarged adenoids, make sure that is addressed before doing anything further in the middle ear. Thanks.
Great. Carolina, any contrary opinion?
About that, I don't really have experience about that, but as I understand, it depends on the indication. If the indication is well done, it could have a role, but to be honest, I don't have personal experience.
Thank you very much. So we take another question. This comes from Constantine. Is there a possibility to use only perichondrium as a graft for tympanic perforation? Or does it always go with cartilage? Yeah, Tashneem, I start with you.
Absolutely. I mean, perichondrium is great. It's thin. It's if you can harvest perichondrium instead of taking the entire cartilage, then absolutely. I mean, I have removed perichondrium, but I usually use them together because my indications for using cartilage is patients who have either had second surgery or there's a retraction. So if you're going to use perichondrium, then it would be the same indication as temporatus fascia. So if it was primary surgery in a well-ventilated ear, because obviously it's thinner, it's as thin as fascia. But absolutely, I think perichondrium is a great tissue for grafting.
Stefan, what's your experience?
Definitely yes. Actually, we have replaced everything what we did with fascia only. We've replaced basically by perichondrium. What are indications for only use perichondrium? First surgery, a relatively small hole, for instance, a persistent defect after grommets. And what would be more for cartilage and perichondrium compound transplants, larger defects, revision surgeries, or severe like adhesive processes, for instance. But definitely yes.
Carolina?
Yeah, totally agree. It's easier to harvest than the fascia. You can do it without going back the ear. And also I like this technique, I call it the island technique, where you measure very carefully your perforation, you keep the cartilage specifically to fit the perforation, and the extended perichondrium goes outside when you go outside with the graft. And I have very good experience, very good results. When you use only the perichondrium, it's also fine.
Appears we have almost a consensus opinion here, but Agarwal, any difference? Anything different to say?
Yeah, not really. I tend to use cartilage, even for most cases. I think I've just kind of gotten into the habit of doing that, and I find it provides a durable repair. So I'll keep the perichondrium, that faces the drum, and then the cartilage piece of it faces the middle ear. And, sometimes I'll crush it if I want to have more pliability of the graft.
Over to Basura to take maybe 2 more questions thereabout.
Yeah, thanks, Titus. I think we're actually out of time at this point, but I'd like to thank everyone. Unfortunately, there's so many wonderful questions and we could go for a long time. I apologize to those that we won't be able to get to the questions, but I really would like to thank all of our speakers today for a wonderful series. This is wonderful topics. Thank you for your time. I'd like to thank everyone who called in and sent your questions and registered for this. I'd like to turn this back to Dr. Serna to close the session. Dr. Serna. I think you're muted, Maria.
Thank you. That's the most common, I think, comment during the Zoom presentations. But anyway, thank you very much. I want to thank everybody for participating in the Global Grand Rounds. Thank you for all of the insightful presentations. It was a real pleasure to see all of the participants from various parts of the world. I want to let you know that we have another Global Grand Rounds planned for November 22nd of 2025, and this is going to be on sleep apnea management and multi-level surgical approaches to treatment of the disease. It will be in collaboration with the Indian Academy of Otolaryngology and Head and Neck Surgery and the International Surgical Sleep Society. We also do have a sponsor, Inspire, who will be sponsoring those Global Grand Rounds. Inspire is a manufacturer of the hypoglossal nerve stimulation therapy. So we also, as the Academy, we're committed to improving the practices of work around the world. We have an initiative that we started, Otolaryngology Patient Scenario Series. This is 60 online case-based courses, and they're currently available for international physician members for free. It's real-world cases. You can do your those cases and learn at your own pace, get a certificate for completion, and also you'll be able to implement what you learn into your patient care. And there's a QR code on the bottom if you want to learn more about it. I also encourage participants to join the American Academy of Otolaryngology Head and Neck Surgery. We do have discounted rates for membership based on also where you're from. For low and lower middle income countries, we do have really discounted rates. And the information is going to be sent to the participants via email after this event. Also, we have the annual meeting that's going to be taking place in Indianapolis, Indiana in October of 2025. Indianapolis is the crossroads of America. It's a home of Indy 500. It also happens to be my home in the United States, believe it or not. But anyway, so this is it's a meeting that's going to be attended by people from all over the world. We'll be talking about various issues that are going to be pertinent to global challenges in otolaryngology that transcends all the borders. Monday is the International Day, so there's going to be a lot of events planned for there, including Eugene Myers' international lecture and international reception. So don't forget to register. Register before August 12th, because that's when the discounted rates disappear. So look forward to seeing everybody in Indianapolis. And thank you very much. Once again, I want to thank all of the participants for joining the Global Grand Rounds. Your certificates will be sent to you by next Thursday via email, and also the recording of the session will be shared. The link will be shared via email after this event. And I look forward to seeing you in the future Global Grand Rounds. And thank you very much. Enjoy your weekend. And again, thank you to all the panelists and the participants.
Thank you.
Goodbye.